I think we move on to the next panel discussion.
Thank you.
Okay. Dr. Supe will come and moderate the thing.
I think thank you, Sandeep, for starting the discussion and Sujay for really moderating it. I think can I request organizers to put one more chair so that I think we can accommodate Sujay. This is going to be panel on portal biliopathy, which is also called as portal cavernoma cholangiopathy. And as of all of you know, this is going to be a case-based discussion. I would like to thank all the scientific team, Dr. Sanjay Mondal, my panelist. I would like to invite all my panelists, Dr. Mahesh Thombare, Dr. Ragini Kilambi, Dr. Prateik Poddar, and Dr. Girish SP. I will introduce to them over a period of time. I think, as you know, portal, I will just introduce the topic in about few minutes. Portal cavernoma cholangiopathy or portal biliopathy, it is called as, defined as abnormalities in the extrahepatic biliary system, including the cystic duct and gallbladder, with or without abnormalities in first or second generation of biliary ducts in a patient with the portal cavernoma. And this is from INSAL consensus in 2014, which is a very landmark kind of a paper into this. And it is also, if you look, due to the paradocal and epidocal venous plexus compressing the common bile duct and vascular injury leading to ischemia and fibrous stricture. So there are two components to the whole cholangiopathy. One is the dilated vessels causing compromise and the vascular injury. The compression is one aspect, but the vascular injury is also one other aspect, which I think Sujay was talking, that some components recover and some components do not recover after the shunt surgery. So we should be very clear about what is the pathophysiology. And biliary changes on cholangiography ranges from 78 to 100% in most series of EHPVO. However, symptoms are only 5 to 50%, but in most of the places it is 5 to 10%, though it is reported up to 50%. And 14% of patients with EHPO with portal cavernoma cholangiopathy develop symptoms of biliary obstruction. So this is what is the statistics. Then if you really look, there are a lot of endoscopic features of various types, from extrinsic compression to shallow impressions, irregular duct contours, stenosis, upstream dilatation. And if you really see now, there are enough kind of reconstructions which can be done where we get a clear idea about what is the kind of portal biliopathy we are. In fact, I would like to say two things. There are types of portal biliopathy and grades of biliopathy. Type 1 is involvement of extrahepatic ducts only. Type 2 is involvement of intrahepatic ducts. Type 3A is extrahepatic duct with unilateral intrahepatic duct. And type 3B is extrahepatic with bilateral intrahepatic duct. And this is from Chandra et al. And this is a quite old kind of an type classification. These are the types of biliopathies, type 1, type 2 and type 3. There is a grading of cholangiopathy, basically on MRI best. That is, grade 1 is irregularities and angulations of biliary tree. Second is indentation and strictures without upstream dilatation. And grade 3 is strictures with upstream biliary dilatation. And the dilatation is defined as ductal diameter of more than 7 millimeter in extrahepatic and more than 4 millimeter in intrahepatic ducts. And this is also from GUT 2011, which is we follow for the classification. This is just to make just a baseline understanding of types and grades of portal cholangiopathy. Now there are different ultrasound images. You will find MRI and MRCPs are used extensively for making diagnosis today, which can give you clear idea about it. ERCP was used once someone would make a diagnosis, but now it is used sparingly with some kind of a treatment, because ERCP in the initial phases used to worry about bleeding, but now with the newer techniques, which our gastroenterologist friend will tell us how they reduce bleeding. And splenoportogram, which was used by us way back in 80s, has now been fairly replaced by CT and the MRCP. So if you get now pictures like CT angiography like this, and we can really get an idea about this. Now I have a wonderful panelist, and I have Dr. Sujoy Paul, whom I don't have to introduce. He is the professor of GI surgery at AIIMS and a great experience into the portal hypertension and EHPVO. Dr. Mahesh Thombare, Dr. Ragini is the expert in EHPVO and pancreatobiliary cancer. She is associate professor in Department of HPB Surgery and Liver at ILBS, and she has also a lot of publications in this area. Dr. Mahesh Thombare is surgical gastroenterologist and professor at Divai Patil Medical College at Pimpri, Pune. Dr. Girish is again surgical gastroenterologist, has worked into various major centers and now as a consultant GI surgeon at Aster RV Hospital, Bangalore. And Dr. Prateik Poddar, who is our gastroenterology friend from Kolkata, who is he's expert in hepatology, advanced therapeutic endoscopy, and he's director at Gastro Kolkata and consultant at ILS Hospital and MRI. And he is also trained in Mumbai. So nice to meet you and thank you all of you for coming. And since this is a case-based kind of a discussion, what my pattern is going to be, I'm going to give a case, I'm going to ask you to comment from the various panelists, and then if there are some audience or any delegates want to comment or quickly, then I think we will take those comments at the same time. Now, my first case is 27-year-old female, history of upper GI bleeding 8 years at the 8 years age, diagnosed extrahepatic portal venous obstruction. She is on endoscopic surveillance. She has no symptoms at this stage. Ultrasound now shows dilated IHBR and dilated CHD 8 mm with distal smooth tapering. Now, so the case is she has been diagnosed at the age of 8 years. Last, say, 19 years, she has been on endoscopic surveillance, asymptomatic at present. Now, my question to any panelist is, what is the next thing? These are the LFTs, like bilirubin is normal, ALT, AST is normal, alkaline phosphatase is slightly raised, albumin is 4.1, and PT INR is normal. So, I think anyone can really take, who wants to really go first?
I think, sir, this is, I think, a straight cut case that your patient is there who has no symptoms, who has been on endoscopic follow-up, not bleeding at the moment. I think for us, we would rather follow up the patient on regular intervals. And that's what we do.
Yeah. So, asymptomatic patient, does everybody agree with that? Anybody is takers for the prophylactic shunt, or anybody wants to interfere into at this stage?
I would first get an MRCP, document the extent of baseline portal biliopathy. She may be asymptomatic from the clinical point of view, but ultrasound shows radiological changes.
This is MRCP.
So there is
you said it and I asked for it. Yes.
So there are obvious radiological changes of portal biliopathy are there. She's got biochemical evidence of portal biliopathy. She's had a bleed.
She has a alkaline phosphatase slightly raised.
There's mild transaminitis.
Is normal.
For 27-year-old, a 42 of transaminitis, there is transaminitis, there is elevated alkaline phosphatase, cannot refute the presence of biochemical evidence there. And she has had a bleed. She's not bleeding any longer, but she's had a bleed. So, in my opinion, she would be a candidate for a shunt surgery, followed by to be kept on surveillance or follow-up.
Fine, sure. So there's one opinion where we would not like to do anything. One opinion is to say we would like to do surgery. Yes, Mahesh, what do you feel?
Yeah, I think we should take the treatment in the form of, or classify the treatment in the form of whether she requires anything for the biliary system. Second thing, if she requires anything for the portal hypertension. And third is obviously when you do one or second, if the patient is not responding, then she requires something. So all these three stages we should ask questions. So here biliary wise, she doesn't require any treatment, including what I mean to say is sphincterotomy or stenting of that sort. But she is a bleeder. Now here there will be two thoughts basically, whether to treat this patient early before she becomes an irreparable kind of a patient where there will be stricture and you do shunt, but that time it won't work probably because there will be ischemic changes into the bile duct. But in India, like the AIMS people, they think even prophylactically. So here the patient has bled actually and has reached the stage where, of course, she has not bled after that. But if you treat portal hypertension, that could be a case which is fit for, I would say, improvement in biliary function would be seen. So rather than doing late treatment, she can be a candidate, maybe a soft indication for doing shunt
You're calling
surgery.
it as a soft indication.
Yeah,
right?
because
This
she is
what you
not
mean by
bleeded
soft
in the
indication.
last 8 years. So this is
18
not
years,
yeah,
19
18
years.
years.
And she is unmarried. She says, do I really want to undergo the surgery before marriage?
Yeah, but obviously you will have to consult the patient. These are the future problems you can see or face.
Fine, sure. Girish, you want to say anything?
See, as you had mentioned earlier, this 8 ductal dilatation is there. So that means it's a grade 3. So grade 3 means if we consider the grading as important in the follow-up of the patient, that means it's significant. But if it does not correlate with the liver function test or any other investigation or absence of any CBD stone, then maybe we should watch and either better is a close follow-up and
Fine,
frequent
sure.
imaging, and then
So you
any,
have a good
any
surveillance
deviation-
on her. That's what you are trying to say. See, I think most of the literature today, if you go through, it is, it's a biased by the gastroenterologist, to be very frank. It is not biased by surgeons. So surgeons may say we would like to do prophylactic shunt, but the literature is biased towards gastroenterologist. So Joe, you want to say anything?
I would agree to go ahead and do a shunt, sir. But
Okay,
in this case,
fine.
we will not refer to it as a prophylactic because
She's already bled once, but 19 years ago. And no bleeding now. Yes, Chetan, you want to say anything?
Sir, the philosophy is very clear. This patient has portal hypertension. Your imaging features are showing biliary dilatation, as he said, 8 millimeters. And if you follow the natural history of portal biliopathy, it is just going to increase. And by doing a surgery right now, you will get over with one stage surgery of just a shunt surgery. Otherwise, if you wait later on, when it becomes ischemic stricture, you will have to do a bilioenteric as
Fine,
well.
sure.
So surgery should be done when the
Do you
patient is
think
complete.
by doing surgery you will reverse her dilatation and
Possible.
alkaline phosphatase?
Absolutely, sir.
What is
Possible.
the experience of the crowd here or anybody who has done these kind of surgeries in him and found out that the alkaline phosphatase goes down and probably her biliary dilatation will also change?
So we've been
Because
looked-
probably she has not developed ischemic component yet.
Exactly.
So
right.
at this particular stage, if you feel it is likely to improve, then do you think it will improve her
Definitely,
compression
because
component?
right now she has varicose type of varices. Later on, once it becomes a fibrotic type, it is going to cause ischemic changes. So it has been
Sure.
seen that there is
Fine.
reversal
Point
of
noted,
LFT.
Chetan. Does gastroenterology departments do agree with this?
Sir,
Anybody else would agree
surprisingly,
with this?
surprisingly, our gastroenterologists send us these patients.
That's okay. No, but Akash doesn't agree in his in publication. So we have these 4 options: continue surveillance as it is. Yeah, please ask Mohan. No? Yeah, sure, Mohan.
Two things are there. One is she is a young patient, how long to follow up, the whole number of years ahead of her. Second thing is I'll go in for prophylactic shunt, and if gastroenterologist tell me, do a endoscopy, and if there is varices, he has to agree for it.
Fine. So you will operate for with the varices, not for the biliopathy. Convince the gastroenterologist. But he would say, I will sclerose them.
So being a student
I'm
doctor,
just being devil's advocate, okay? Just remember that because I just want to look at the literature. Yes.
So one more thing, in this thing we have to see about the hypersplenism.
Hypersplenism. How big is the spleen? As I said, I said in the beginning that if you see large spleens, sometimes used to do PSRS or something like that. But that was one thing which many people still don't know after doing PSRS, what is the pressure goes down into the varices, though they say most of the time it goes down, but I'm not very sure whether it will reverse this change. So that's another point which we need to also think. It may reliever of splenomegaly, it may reliever of portal hypertension, but we don't know what effect it will have onto the portal biliopathy. So these are the questions. As you know, this is our Indian disease, more common. We need to find all these answers. And this is where we need to contribute and share our research and get publications. Anand, you want to say anything?
Around 2 patients presented like this only, and they underwent endoscopic ultrasound in our AIMS only, and they found there was actually a dominant collateral at the lower end of the CBD, And in one patient, actually, we did some surgery, and that patient has improved post-operatively.
Fine,
So
sure.
again, so
Anecdotal,
she's a very good,
but
yeah.
need to watch.
Yeah.
We need to study those pressures and
Yes.
see how much is the ischemic component, how much is the compression component.
Yes.
See, these are some questions which are still not answered even in after so many days. Puneet, why don't you come and sit here in front? So these are some questions which are still not being answered in our mind, and we need to look at this. But if you look at the literature, again, as I said, it is predominant by the gastroenterologists, which would say that no biliary intervention required, manage portal hypertension, like everybody has said, portosystemic shunt surgery, decompressing varices and relieving CBD obstruction due to protruding varices, regular follow-up. So we really have to really look at this, so everybody would manage a portal hypertension, maybe by doing shunt.
One more aspect, like we were discussing, that even if she has varices, we can do endotherapy. There is some evidence to suggest that actually long-term endotherapies redistribute the pressure. So the gastric varices are gone, but the pressure is now on the pericholedochal varices. So they can actually lead to worsening of the portal biliopathy, and then
By
those
doing
can
sclerotherapy or banding.
banding.
What is your opinion, Prateik?
So the data is still not very clear on this. I mean, there is no definite evidence which says that there will be increase in the biliary ischemia or there will be biliary strictures. So we are still going through the endoscopic variceal ligation and everything. And what we follow usually is, our main concern with these patients is parenchymal extinction. So therefore, as a hepatologist or a gastroenterologist, that is what we are worried about, because ultimately that is going to change the prognosis of the patient.
Sure. I remember in 86, we used to do all experiments. We used to take dogs, we used to take and inject that contrast. And I remember when this gastropathy word was introduced in 88 conference, that time those questions were there. They are still in our mind. They are not yet solved. So we are still worried whether by doing an endoscopic variceal ligation, are we really increasing this peridocal or any other kind of natural shunts which are increasing, and do they really worsen? This question still remains in our mind because we don't have a proper follow. Yes. One or two last questions and we'll go to the next case.
What you are talking about, that endoscopic sclerotherapy increases collateral. This is a study by Dr. Sarin, which was published in Gastroenterology long ago in 1992. Yes, it does increase gastric varices. It increases portal hypertensive gastropathy, but there is hardly any data whether it increases biliary or biliopathy. Now, the other side is subsequently a study by Dr. Sarin published in 1995 in Journal of Hepatology showed that actually endoscopic variceal ligation does not increase portal hypertensive gastropathy or gastric varices, which is quite understandable. The reason is when you are doing EVL, you are not blocking the collateral, and this has been shown by EUS study from our department as SGPGI, that when you do EVL, you don't block the collateral, you only block the varices, whereas when you do EST, actually you block the perforator, and that is the reason for increase. We don't do nowadays EST, we do only EVL, and EVL doesn't increase collateral blood flow causing GV or PIG.
Sure, I think that's a wonderful point. We used to do a lot of morphological studies of post-mortem studies on the esophagus of patients who died. And then what we had realized that when we are really blocking these vessels, we are creating a lot of peri-esophageal vessels. And rather than intraesophageal or intramucosal vessels, we are converting all that patient into perivesical. But whether it reflects onto the portal biliopathy, we really don't know. So that question still remains unanswered. And the second question still remains, as I said, the gastroenterology medical law literature says you don't do anything to the varices biliopathy. You may do a shunt, like what our surgeons have said, to reduce the portal hypertension. But that depends upon the case to case. And as somebody said, your splenomegaly, your pressure, factors, and there is the other side also where people would just conserve and observe. So that's the take-home message like this. With this, let's go to the second case, which is what we normally face. This is a 31-year-old male, abdominal pain 1 month, progressive jaundice for last 15 days, fever for 5 days, history of upper GI bleed in childhood, was diagnosed as EHPVO. Total bilirubin today is 10.4, direct bilirubin is 8.1, alkaline phosphatase and AST, ALT is raised, albumin is 3.5. and this is his MRCP, which shows stricture at the mid common bile duct with upstream dilatation. What is your approach?
So we would proceed with an ERCP in this patient because there is of course cholangitis in this patient. There is biliary obstruction. So in such patients, when we do the ERCP, the main thing is there is a risk of bleed which is there during the ERCP intra procedure. And of course, these strictures, we usually try to dilate the strictures to a larger extent because to prevent further complications. So what we do is we usually put in maybe
what are your tips and tricks of preventing bleed during ERCP?
So we use terlipressin. So standard we use terlipressin during the procedure as well. So patient is pre-procedure also the patient is put on terlipressin, and during the procedure the patient is put on terlipressin. We have now shifted from bolus to infusions, which work better, have less side effects of any other sort. And we, during the procedure,
even if patient is in shock, you will use it? Baby.
Yes, terlipressin so definitely we are using. So patients are resuscitated before we take the patient for ERCP anyway. So once the patient is fit, only then we can proceed with ERCP. So when we are doing the ERCP, of course we are putting multiple stents possibly in these patients to release the stricture.
What kind of stents?
So we are using plastic stents in most cases. Of course, metallic stents, nowadays we do have removable metallic stents as well. But there is of course not much data and not much experience with them. It has been used. But plastic stents, the standard plastic stents, so we are starting with a 10 French stents, so maybe 7 French, 10 French depending on the diameter which is possible. We use Sohendra biliary dilators to dilate the strictures whenever possible and feasible. But the problem is in such patients there is a risk of bleed. So in usual cases, pre the ERCP we'll do a EUS, and that will help us in finding out what is the risk of bleed, because we will be able to see the pericortical and epicortical varices very well. So we can see those vessels and we can see and we can diagnose the sort of risk that we might be facing.
Sure.
That is there.
Any other comments anybody wants to make, other panelists?
But even if you do the US, suppose there is a collateral, will you stop doing the ERCP?
So we will be more careful. I guess we have faced a few complications where there has been patients who had bled during the procedure, even with all precautions. But we will tend to be more gentle with the procedure. That is the only thing which we do.
One thing I must tell you, when somewhere from 2000 to 2008, we must used to see at least once in a year we used to get patients like this. Today I think gastroenterologists have learned how not to cause too much of bleeding. Yes. So I think whatever your techniques are, they are working and we are not getting patients who are bleeding. Puneet, you wanted to say something?
Papillotomy and use a balloon instead, a balloon papillotomy rather than a...
No sir, actually when we go for this procedure, the sphincterotomy has to be done. We don't do a wide sphincterotomy anyway, and we don't need to. We just need to put in stents. So unless and until we are removing a big stone, we don't really need to do a wide sphincterotomy, and we don't need to actually dilate sphincteroplasty as well. The bleed risk is also there with sphincteroplasty. In fact, even balloon sweeps have found to have that. In fact, I have faced a scenario where a simple balloon sweep has caused a massive gush of blood coming out from the CVD. No, I understand. I'm talking about sphincteroplasty as well.
Just the papillary. Yeah. Just to facilitate the stent, normally you do
just papillary dilatation.
Standard sphincterotomy would be sufficient for us to put stents. At least you can put 3 stents itself. If the stricture is
so your main
adequate.
aim is only to relieve the cholangitis and obstruction. That's all. That is
so I would put as many stents as possible. That is the
7 French also okay, or 10
I prefer putting 10 French stents and as many as possible. So there was a Costa Magna protocol which we follow. So maybe 2 to 3 stents going in, and we would leave them for around 3 months or so, and then we would exchange the stents for again as many stents as possible.
Sure.
And that would be followed up for a year, and those strictures would hopefully relieve, and we get patients who have relieved the strictures to a large extent. But of course, they have the strong ischemic strictures, then that's a problem, sir.
Sir, but here the patient is not in cholangitis. There is nowhere in your investigations you have said there is cholangitis. You have just shown us LFT.
No, there's fever, no? Fever is there.
Alkaline phosphatase is raised slightly.
No cholangitis, but no cholangitis. So basically, if the patient is not in cholangitis.
Chetan, I have taken an example which is just borderline to just make a discussion.
So if what I would want to know is if it comes to a surgeon upfront, rather than going to a GI physician, what his approach would be different?
What is the role of shunt surgery? Would you really think about shunt, and if so, what at what stage?
First, this patient is definitely a candidate for shunt surgery, but at a later stage, first he has to be optimized. We would not like to do a shunt surgery at a bilirubin of 10.4. Sure. So therefore, we would drain the patient, with or without cholangitis, drain the patient, bring the bilirubin down, simultaneously evaluate with a cross-sectional imaging for the patency and availability of the splenic vein, and then plan for a shunt surgery as the first step of a possible staged procedure, or whichever, whether if he goes for stent
So you would
trial.
think about 2 or 3 stage procedure at a later date. Anybody else has another thoughts, any other comments anybody wants to make from the audience? What will you do with bilirubin 10? You don't want patient to remain with alkaline phosphatase high and bilirubin 10. So maybe, I'm sure I should have given INR also, but I think that is something which I should have given. Yes, you want to say, Girish?
If the patient had bleeding during ERCP, definite shunt. Otherwise, I will wait and allow
I think I'm going to
endoscopist
ask
to.
all panelists how they stopped, what do they do when there is a bleeding during ERCP?
No. Is following ERCP, once the bleeding has stopped, I will definitely consider, because he may require.
At a second stage.
He may require further ERCP
Fine,
and
sir.
all. So then
You would like
definitely
to do at a second stage a shunt surgery. Yes, Mahesh?
I want to ask the medical gastroenterologist, does he need to place, say, 2 or 3 stent in one go in the first place? Because our aim is to just relieve it, because at that time if we create complication, that would be difficult to salvage
Fine.
also.
So why do you put multiple stains? That is his
Yeah.
question.
In the first place.
Yeah, that's what I'm saying.
So I got the question, sir. The thing is that we would rather want to reduce the number of procedures we are doing for the patient, and placing the stent usually does not cause too many complications. It is mainly sweeping procedures and cutting procedures which cause the bleed, which we have seen. Placing stents, if the wire is going and if it's adequate enough, and we are
Wire
putting
itself does not cause bleeding.
not cause bleeding, and we are putting in wire guided stents, doesn't cause any much bleeding. So we've hardly ever faced, because of course at our center we used to do a lot of patients with EHPVO and stenting. We have hardly ever faced any patient who's had a bleed because of putting in stents. It is the controversy. It is actually removing stents which is more risky in such patients.
Fine, sure.
So that is the thing.
Point well noted.
Would you consider using a spy scope to rule out intracolloidal varix?
Yes.
I think that would be overkill in most
The
cases.
visualization is very good with the spy.
No, not usually. See, the cost, of course, is prohibitive. It is not available at all centers. And I think the EUS followed by the ERCP is enough. When we're doing the EUS, we usually find the varices which are there. And even if we're doing the spy scope, even if we find the varix, there is not much which we are changing. We are still going ahead with the intervention. Just we are going to be more careful.
Do you use EUS in every case of ERCP when you are doing in patients of these kind of patients?
Yes, I would prefer. If the
And
patient is optimized and stable, I would.
Advise what kind of information you get from EUS which will prevent you doing this procedure?
Sir, if I am
and
getting,
tell me the first question, what are the tips and tricks of doing this procedure?
So sir, in patients where I am doing the EUS, I would see if there are subepithelial varices which are there, especially in the cortical varices which are there. The risk of bleed is very high in these patients. Then I would have to be more careful when I am doing this. And of course, periampullary varices are very difficult to look for. Though it has been mentioned in the literature, practically speaking, it's very difficult to look for and to diagnose.
Fine,
so
sure.
that is something which.
So you said instead of sphincterotomy, you do balloon kind
yes,
of a dilatation.
Yes, you can do a balloon dilatation mild.
And plastic stent you use removable.
Removable,
risk
multiple
of bleeding
stents.
and shunt. Anyway, anybody else wants to have any other questions? Yes, Puneet.
It's obviously a good gastro center, but I think we should emphasize we get a phone calls from peripheral areas where you may not have good. So, and the second reason for my getting up is that the consensus guidelines for portal biliopathy were drawn up by gastroenterologists alone, with not a single surgeon on board.
Exactly.
So I don't want people here go away that they need to send it to any gastroenterologist in the neighborhood. It has to be done in a good center. If you don't have a good gastroenterologist adjacent to you, either send to a better center, or even if you're doing, for instance, it's even an EMBD or something which is simpler and tides over and gets your cholangitis or the bilirubin down a bit, and then you go ahead with the shunt, would be also
Perfect. I think well said, Puneet. I think what everybody has to take a message is that when you get a complex patient like this, you have to have a good gastroenterologist. Otherwise, everybody has seen the horrors of bleeding and how we have managed. So there are a lot of kind of tips which are there, which you should follow when you are normally putting these stents. Putting a stent looks very easy, but it has its own issues. Yes.
Yeah, actually somebody was raising, does she have cholangitis? Yes, she has. The reason is she has typical triad, that is Charcot triad. She had abdominal pain, she has jaundice, and she has fever. Now what happens is I will have a little difference with your approach. Maybe you are right, but maybe that is what we do. If a patient has frank cholangitis, I will not be comfortable just placing the stent and leave her there. I will put an ENBD, maybe one stent, one ENBD. The reason is ENBD is the one which I can flush. I can see whether it got blocked or not. Instead of putting 3 stents, I will put one ENBD and one stent.
Sure. Thank you. I think let's go to the next. I'm sure we are running out of time, but I have some 13 cases which I'm sure we are not able to finish. So the 3-phase formula is very clear. Manage the biliary pathology is first, I think with whatever technique you do. Second is do portal decompression at a second phase, and then there are different ways of doing. I think Sandeep talked about it, so I won't really go into that. And later on, for the resistance cases, which do not go, after doing a shunt, many patients don't require also this kind of biliary thing, but some of them if they require, then you can think about hepatocogenostomy or choledocogenostomy, or then you can do that. I want to ask 1 or 2 questions. What do you do in these situations? No shuntable vein. So you would do devascularization, you said, and what do you do then to the biliary? You can do, do you do the hepatocogenostomy with devascularization, or you do it after that?
So that's where we we have a lot of difference with the INSL algorithm, where these patients are actually the basket cases and there's not much hope offered to them. In fact, liver transplant has been written in the corollary as one of the options, which I think is also equally bad. There is, in this situation, there is a scope for a direct approach to a hepatocogenostomy in a selected few cases, with the proviso that you tell the patient that it's going to be a risky procedure. It's a high-risk procedure. You might have to abandon and come out. You might have to pack also at some instances, but in our experiences, we have been able to do it in 9 out of 10 instances.
Most of the time, if you lower the plate, you will be able to get an area
Absolutely.
where there are no varices.
Absolutely.
I think this has been our experience also.
Segment
but
3
this
also.
is a calculated risk.
It's a calculated risk. So.
That's what all of us take.
Plus, we use terlipressin during the surgery. I don't know whether it really makes a benefit or not, but yes, maybe it gives you some kind of a
One of
moral...
the problem of portal biliopathy is that you cannot do a Pringle procedure also so well here.
You cannot.
And what are you going to put a clamp and where? So these are all issues which come. Failed shunt or devascularization, what is your choice in these cases? After
Same approach, sir.
Same approach.
Same approach.
So many a times you are forced actually to do an upfront surgery. Basically,
That's what he is talking
while
about,
changing the stents, many instances they have come with perforation. So that is the time. So encouraged by this, we also at our center have done 7 cases. But you need to counsel the patients and their relatives that we may have to back out of the surgery. That's very important.
So there's one more point I would like to add, and this the Gangaram team had highlighted, that devascularization itself in those patients where they went in with the intention of doing a shunt was able to decompress the pericholedocal varices in a few patients.
Sure.
Meaning thereby that splenectomy also may have a role in decreasing the pressure.
Fine, sure. I think most of the people would have a interval between doing a shunt and hepatocogenostomy, but in some cases you can do it before shunt or at the same time, I think so.
So same point. I think there are 2 more strategies which can be used. One is a makeshift shunt. So normally I don't advocate this. Probably the only indication where a makeshift shunt has actually, we did once in Cambridge, once here. And you know, although like you said, it doesn't reduce the portal pressure so dramatic, it doesn't reduce the collateral so much, but it does reduce the portal pressure. So a makeshift shunt is one, and the second is veno-venous bypass. Problem is now that with the, in transplants, we're no longer using veno-venous bypass, so availability might be an issue, but it's good. This is one of the few sort of
Fine, sure. Point
stress.
noted. I think, thank you so much. Let's go to the third case. This is again a very common issue which all of us face while doing cholecystectomy. 60-year-old male, type 2 diabetes and hypothyroid, past history of pancreatitis 2 years ago, presented with right upper quadrant pain, sharp, constant waxing and waning, associated with 2 episodes of vomiting, no history of alcohol use of, right upper quadrant pain, Murphy's sign, and he has a gallstones. The gallbladder is studded with this, and there is varices around the gallbladder. And this is a very common, today we see a lot of either cirrhotics with varices around the gallbladder or pericholedocal varices. So this becomes a technical problem for most of the surgeons. I think when you are doing a laparoscopic cholecystectomy, we always face this problem. So I want to ask, and you know, there's a pathogenic mechanism with chronic pancreatitis, with everything is there. So I want to ask this question to you. What is your approach and what are your tips or tricks of doing this when you are doing it? Will you conserve this patient, or you'll do cholecystectomy, laparoscopic open, or along with a shunt, or you'll do a partial cholecystectomy, cholecystostomy? What would be your approach of tackling the stones in presence of portal biliopathy? Anybody wants to take it? Or audience?
It appears that you've given the Murphy's is positive, so it appears that the patient has acute cholecystitis. So in the setting of EHPVO with acute cholecystitis, I think it will be prudent to first go for a conservative management and do it as a cold interval cholecystectomy, not a hot cholecystectomy.
Point noted.
Then even at the time when we do contemplate the elective cholecystectomy, we should have a roadmap, both in the form of an MRCP for the biliary anatomy to know how much the Hartmann's is away from the duct, what length of cystic duct we have, whether we have a potential Mirizi, and also a contrast enhanced imaging, either a contrast enhanced MR with MRCP or a CECT to look at the extent of collaterals around the gallbladder, so that we can have a mental roadmap of what we are going to expect while we go in there. And then
sure. ICJ also helps in these cases, just to be sure where the duct is. So idea is you have to have a good roadmap about the vessels, biliary duct. You should be prepared for doing partial cholecystectomy. Your main aim is to remove the stone, and you may end up with partial cholecystectomy, keeping the whole gallbladder wall onto the liver. Anybody has any other thoughts on this?
Just to stress what Ragini said, that the combination of cholangitis and hypertension is a killer. So even if you're doing a direct approach, it should never be in cholangitis. It should always be cold, not just in cholecystitis, in all, because all the patients who have that combination die. In the original GB-PAN series of shunts also, the first two patients who died were exactly like that. They had cholangitis as well. So if there's cholangitis, just whatever way you tied it, even if they're going to recurrent cholangitis, long-term, conservative, just stick with it and then do it late in a cold setting.
See, this is a very common problem we face with gallbladder along with varices around, and you have to do cholecystectomy. I think we have to be all ready with these kind of
two
patients.
technical points to be kept in mind while operating. One is that you anticipate varices between the gallbladder and the liver surface. So you keep behind the posterior surface and you do a partial cholecystectomy, either fenestrating type or reconstruct, because the other point of varices will be near the porta. So that is where you have to go ahead and do a partial or a subtotal cholecystectomy. And I would prefer doing it open rather than laparoscopy.
I mean, that I think experts would differ, but I understand. Yes, Subodh is there and then followed by that.
This is an EHPVO portal vein thrombosis and cholecystitis, or it's a chronic pancreatitis induced
normally if it is liver is normal and it's EHPVO, you will call it EHPVO kind of thing. But if the cirrhotic is, I just took the another patient also who has a cirrhosis also along with that. Yes, that's what I said. I just put it this case as this.
One more thing I would like to add, practically instead of using energy sources, put lot of clips and use lot of sutures. Don't use energy sources at all.
But if you do open, many times laparoscopy people would just use bipolar.
Even in small vessels, you keep putting clips.
Sure. Darais, you want to add anything as a technical tip? Sudeep, you are also there. You want to add any technical tip? Yes, Parth?
No. So regarding the lap chole, just want to see. So we are talking about cholangitis or cholecystitis with the pancreatitis, or recurrent biliary pancreatitis. While investigation, you see like portal cavernoma, that's all. Patient is not having any symptoms. So I have a case, my junior already posted a case of lap chole, and the scan shows there was a portal cavernoma. He has started, said there is a case. Then I said, how you posted lap chole, but portal cavernoma, said, wait, I'll come. So I took the case. But what we are all discussing, that not all the portal cavernomas will be difficult. Don't think like that. If you go put the scope is there, all the veins will be covered with the peritoneum. So if you are very much technically, so I can see, I went and see, probably if, if you have the video, you can see. but unless you people see, but everybody is going in a thinking that all the it's not possible. It's not like that.
Point
but all the
is
cavernous there.
well taken. I think I work with now Zen, and we have so many cases like this.
Now
They
even
all are
if
treated laparoscopically with taking all this care.
But you have, as you said, now you have all the gadgets. If you have, you have harmonic scalpel or ligature. If you have a ligature, very well you can take all the varices.
Fine. Point noted.
And another thing is even for the DVAS procedure, very well we can do laparoscopically and with a good results. Yes.
Sure. Daraj, you wanted to make a point?
So most of our situations tend to be chronic pancreatitis rather than EHPVO. So same old thing. I think you start off laparoscopically, have a very low threshold to convert, subtotal, make sure a friend in the building is there with you. And our difficult situation usually comes up is if they've had a long-standing metal stent or 2 or 3 stents, and they've also got some gastric outlet obstruction because of the fibrosis. In that setting, you have no choice but to do a reconstruction. And sometimes if the portal hypertension is really bad, that's the one situation where we will do a side-to-side, just to maintain the collateralization along the bile duct. So hardly any situations where you do a side-to-side biliary anastomosis, but this may be the one situation where you think of it.
Fine, point, good. I think that's a good point he made.
There's a question. We actually do it. I just wanted to ask whether the others do it. Do you start intravenous infusion of octreotide or somatostatin, something, to lower the terlipressin? You do it? You all? Yeah.
During, they made it and mentioned it actually before.
I wasn't there.
Sudeep, you want to say anything? Fine, sure. I think let's go to the, I won't go into this, let me go to the last case because we have only 5 minutes. 50-year-old male, known case of EHPVO since childhood, developed jaundice 5 years back, diagnosed portal cavernoma cholangiopathy, no shuntable vein, regular shunt exchanges, developed ascites 1 year back on diuretics, developed spontaneous bacterial peritonitis and hepatic encephalopathy 2 months back. His bilirubin is 2.3, AST 65, ALT 48, ALP is 325, and if his creatinine is slightly gone up, and he has an EHPVO with portal biliopathy with lobulated liver, contour of ascites. Now, so this is where, what is your management approach in this particular case?
So we are dealing with secondary biliary cirrhosis now. So
we have just taken cases over long-term follow-up because we are seeing all these cases now.
Absolutely, and then we are left with little option but to contemplate transplant at some point of time.
Sure.
Of course, first we'll have to manage the SBP and see if there is any cholangitis which has to be treated. And transplant in this kind of a situation, we have had anecdotal reports from our country. We have Ravi here. You can add.
Ravi, you want to add?
Transplant is possible but difficult because portal inflow is going to be a problem. But then it's possible because what sometimes you can do is you can just take the entire porta and loop it and snug it and then find one of the good collaterals with good flow and then use it for inflow. But other than that, standard.
Do you have any knowledge of any good series or some reasonable, respectable series with this?
No. The other thing is that, if there is lack of good flow in the portal, in one of the collaterals, then you're really struggling. And then you have to do an extra anatomic inflow, and they continue to have the problem of ascites and bleed later.
Sure. Anybody else has experience on this doing transplants, Sudeep or Darais? You are there, so I'm going to ask you this question. Have you done for? I'm sure how much EHPO you see and how much of secondary biliopathy you have seen.
The closest situation is what we eventually land up calling as end-stage NCPF with a bad portal vein thrombosis. I mean, we have 2 options. We also have the option of multivisceral. So if it really is completely pan-portal vein thrombosis, we've sent patients to Cambridge for adult multiviscerals. But invariably, as Ravi says, you will end up finding some vein that you could use at the root of the, at the root of the mesentery or somewhere or the other. Right? Those are huge collaterals on that scan, but there are no pictures, further down. There are no pictures further down. So I think if you've got any vein down there, invariably if you keep flow open for 24, 48, 72 hours, those veins stay open. Our experience, fortunately, is all in cadaveric, where you don't have the pressure. But I think if you have to do it in a living-related situation, I'd be very concerned. We wouldn't select someone like that for a living-related transplant at all.
Okay, it's good to write papers, but
I think that's
it's good to write papers, and it's a good backup option if you have nothing. But
see, many times I think these become sometimes theoretical options, but practically you are always afraid to do these kind of cases.
Yeah.
And as you know, I think there could be a lot of technical issues in. Yes, Sudeep, you want to say?
No, they're just, as Puneet mentioned, there are people where splenorenal shunts have been done. Then you can use the renal vein as the inflow because the circulation just goes.
Okay. I think that's important. I think there are always technical issues in liver transplantation also, which I'm sure we are not going to discuss because we have to, already time is up. But I think if you realize, I think if you really look, EHPBO has its protocols. Most of them are, as I said, are gastroenterology people created protocols. As Puneet rightly said, that most of the protocols are made by the gastroenterologists and they are towards all endoscopy and all. But as a surgeon, we still continue to see cases of this in our practice. And we need to find our own solutions. And by understanding and discussing like this, we will have to find out the solutions and develop local protocols based on the local expertise and many other factors. So as you say, most of these patients don't require any surgery, but some of them will require surgery, require a very high skilled and analytical mind before we really like to do it. And many times, as Sujoy rightly said, it's a calculated risk which you are taking on this side or that side. So at the end, I would like to really last 1 or 2 comments if the audience wants to make or any clarifications to my panelists, I think you can really ask. Otherwise, we are ready to close this session. Any burning questions? Any questions you want to really ask? Do you need a normal bilirubin for shunt surgery?
I'd be happy to do if cholangitis is sorted with a bilirubin of 5, it's fine, but not at 10.
Sure.
There are basically not much we can do. We can give 20%. Okay, we can call the surgeon and we can pay to go.
In this, in that setting, would you prefer using a covered stent?
So the problem is, whenever we are at the table, so there are a few practical problems which we face. First of all, cost is an issue because when you're having a covered metal stent, the cost is extremely high. So when you're doing a practice, you have to explain to the patient.
Can it be life-saving, but at times?
Yes, sir, it can be. But again, I have seen that there's no difference if you're packing with stents, suppose 3 or 4 plastic stents, or you're packing with a metal stent, it's almost the same because the diameter achieved is the same. So the distension and the strength is the same. So you end up with stopping the bleeding if it has to stop. If the bleeding doesn't stop, even after that, you have to go in for an emergency procedure. I mean, a surgical procedure is indicated.
Sure. I think somebody in the back, yes, you want to have comment? Yes.
Gallbladder is still dilated and then it still has bile in it.
I think I remember many years ago people used to do cholecystogegenostomy, but I think it's given up many long. I don't have personal experience for these patients. I would do a careful subtotal cholecystectomy rather than going for cholecystogegenostomy. But anybody else has experience on
in the case which you showed, the gallbladder is dilated, it has stones, patient is young, there are strictures lower down.
No, I understand. There's a alternative is there, but
If the cholangiogram shows that the strictures distal to the joining, I think that's it's normally, meta-analysis has shown that cholecysto is inferior, but that's in the kind of situation he's saying where, you're slightly desperate. If your cholangiogram shows that it is distal to that, it's probably a valid option. The
fine, you can do.
main,
See, but most of the time
stricture.
I've seen these patients have an impacted stone at the lower end and gallbladder. That's the problem. Unless you remove that, and then in that necrotic gallbladder, trying to do a cholecystogegenostomy may not be a good option. So it may be a situations you have to really see, I think so. Anybody else has any other points? Otherwise, I would like to thank my panelists and thank you so much for your all cooperation and comments. Thank you so much.